Yes. Right, so we're live now, and I think we've got a few people joining us now. I can't see how many people are joining us at the moment, but I hope you're here. So welcome to the first Liverpool Dementia and Aging Research Forum in 2021. So many people have registered, and as they're joining us now as we speak. So very excited to welcome today Dr. Catherine Lord and Dr. Sadia Paveen from the University of Bradford's Centre for Applied Dementia Studies. A quick overview of Dr. Catherine Lord's work. She's a Senior Research Fellow at Bradford University, and she will be talking about developing and delivering an online dementia training course for home care workers as based on the NIDA study. We'll also have Dr. Sadia Paveen, who's a Research Fellow at Bradford as well. And she will be talking about improving the dementia care pathway for minority ethnic groups. So welcome to both. And just before we are starting off with our first webinar of this year, please post your questions throughout in the question box. And we will have about 15 minutes or so at the end for Q&A with Catherine and Sadia. And also, if you are on social media, if you're on Twitter, please feel free to use the hashtag Liverpool Dementia throughout to share your thoughts about this webinar and connect with others. So without waiting any longer, over to you, Catherine. Floor is yours.
Thank you, Clarissa. Good afternoon, everybody. And yeah, as Clarissa said, I'll be talking about some of the work that we've been doing as part of NIDA. So I'll keep using that acronym throughout. But NIDA stands for New Interventions for Independence in Dementia. And this is a 5-year programme grant that I'm a co-applicant on that's funded by the Alzheimer's Society, and it's led by Professor Claudia Cooper at UCL, and we're also working with colleagues at King's College London, the University of Exeter and the University of Reading. And like Clarissa said, today I'm just going to talk a bit about some reflections on some training that we've delivered to home care workers. Obviously, in the past year, we've had to change how we've delivered this training. So we thought it might be interesting for you to hear a bit about how we've made those changes and how those changes have gone. I'm going to be a bit of a Chris Whitty, and I'll just say, Debbie, next slide as we go through. So if you could do the next slide for me, please, that would be great. Thank you. So just to give an outline of what I'll sort of talk about in the next 20 minutes. So we'll talk a bit about the background of NIDA, so why we felt that this programme was necessary, and then exactly what the NIDAS programme is. There's 2 components of it. So I'll talk a bit about NIDAS Family, but I'm going to focus today on what we've called NIDAS Professional, which is the home care worker training. And then I'll talk a bit about the findings from a pilot that we completed just before Christmas, and then tell you about our next steps for the project and where we're hoping that it goes. So next slide, please, Debbie. Thank you. Lovely. So this is not an exclusive thing to people with dementia, but most people do want to remain living in their own homes for as long as possible. We know this. And one of the ways that this can be enabled effectively is through using paid home care workers. So we call them domiciliary care staff, but this is really anybody from either an agency or a private individual that will come to your house to help you with daily tasks, really. So they can do anything from maybe helping with reminding you to take your medication, or helping you get dressed, shower, eating. Some of the visits that these agencies provide are actually more kind of companionship visits. So they go and provide company to individuals, maybe take them to the shops, or if they've got any hobbies or activities, they help to facilitate that. So that's the group of professionals that we're talking about here. And just before we started the NIDAS project, the Alzheimer's Society produced a report that said that actually only 2% of people who are affected by dementia felt that these home care workers had sufficient training. So really, as a profession, they receive very little support and training, and particularly around dementia, it's not the norm that they would receive dementia specific training. So we saw that there was a real gap and a real need if these people are going to be providing such care to people living with dementia. Next slide, please, Debbie. So sort of in response to that gap that we saw, the aims of NIDUS really are twofold. So we have two concurrent kind of work streams. So we have NIDUS Family, which is a training and support programme specifically aimed at family carers of people living with dementia at home, which I'll talk a little about, but won't be the focus for today. My email's at the end of the presentation, so if anybody has any NIDUS family specific questions, by all means do drop me an email and I can put you in touch with the researchers who lead that. And then we also have NIDUS Professional, like I alluded to. So this is with paid home care workers to provide high quality care and support independence for people living at home. That's what we're really focused on, is how can staff provide the best care possible and how can they let people live as independently as they wish. Next slide, please, Debbie. So we designed these two interventions, so these training and support interventions, in kind of three ways. So we obviously looked at the previous research, so what had previously been done, and there's been quite a lot of work done in the States, in America, around interventions to support people to live at home for longer, and also in Australia. So we've worked with these colleagues about what worked for them and what didn't, and learnt from their lessons. And then we also interviewed people in the field. So we interviewed people living with dementia, we interviewed family carers, people who were receiving home care, so people who were having paid carers come in. What was it like for them? What was working? What wasn't? And then our researchers conducted observations. So they actually shadowed paid home carers going into people's houses to sort of get a sense of what they were doing. People can be quite self-deprecating and say, oh, you know, all I do is go in and help with their medication. But actually, what they're doing is a number of things. They're checking on the safety of that person. They might be the only person that individual speaks to all day. So actually, they're providing kind of really vital lifelines for individuals. So we really wanted to get an understanding of what was happening in practice so that we could create the most appropriate training and support for them. And then we held co-production workshops. So these were events held over a number of months with family carers, people living with dementia, home care workers themselves, and other healthcare professionals that we felt were relevant, and they helped to design the two training and support packages. So I'll just tell you a bit about NIDUS Family on the next slide, Debs. Actually, you can skip 2 on if that's all right. So for NIDUS Family, what we have created is a series of sessions. So these are carried out by researchers that work in our team. And what they do is they meet with the person living with dementia and a family carer. And the first thing that they do is they set 3 to 5 priority areas. So they say to an individual, what would you like to work on over the next 6 months? A weakness of some other dementia research in the past that we have found, that we've conducted, is that if you have these quite sort of academic, abstract outcomes for your research, it may be that you don't actually show any improvement through your work. So what we were trying to do was use something that's called goal attainment scaling. So this was individually tailoring interventions to each person based on their goal. So somebody's goal might be that it's quite difficult with COVID, but that they wanted to go to the shops more often, or that they wanted to go and see family and friends more often. So we would focus specifically on the goals that they had set. So once they'd done that, they would meet with the researcher, and again, this has all moved online because of COVID, up to 8 times to work through sessions that we had co-designed to support these goals. And the manuals contain sort of strategies, resources and exercises that are accessible for the person living with dementia and the family carer. On the next slide, Debbie, you'll see here we've created a roadmap for this part of the project. And essentially, I don't know if you can see the little red car that's just after number 4, but we're currently we've piloted this with a group of individuals, and we're now testing it out on 297 couples of people living with dementia, so dyads we call them. At last count, I think we were on 94 people consented, and we're going to be recruiting we'll be finishing the trial in March 2023, which sounds a long way away, but we're already in 21, so it's going to be here before we know it. So currently, that's what we're doing with NIDA's family. I'll give information at the end. If anybody is interested in participating, we are still looking for people for that part of the study. So that's just an update on the family aspect of it. But if we just move on, Debbie, you can go 2 slides forward again, if you like, is about NIDA's professional. So this is what I'm predominantly going to talk about, is the training that we provided to home care staff, and we're going to provide to home care staff. So these are the 6 sessions that we have created, and these have been co-designed again. And the original plan was that these would have been 2-hour face-to-face sessions based at the agency. So the staff would just have to be at the agency, and myself and another colleague would facilitate the training of these sessions. But then obviously COVID happened, and it was decided by everybody that obviously face-to-face training was not it's not a vital kind of service and something that needed to carry on. So we decided to try to adapt these sessions to being delivered online. And if you move on to the next slide for me, Debs, I can show you where we are in terms of the NIDA's professional roadmap. So we spent last year obviously having to adapt the sessions to be delivered online, but we have now successfully delivered all 6 of those sessions to one agency. And I'll go on to talk a bit more about the other steps afterwards. So on the next slide, Debbie, for me, we've got here what we actually ended up doing. So there was a lot of talk firstly about the platform that we were going to use, whether we would use Teams or Zoom or Skype for Business or all these other ones, but we ended up on Zoom, and that was actually through discussion with the agency. They seemed to feel that a lot more people were using that in their everyday life. This was kind of at the peak of Zoom quizzes and all of those sorts of things, so it felt that Zoom was the appropriate software to use. And we recruited we've put 6 to 7 home care workers. We've still got one person who hasn't quite finished all of the sessions, but they're hoping to do so. And we began the training on the 12th of November. And the way that we adapted the sessions was that they became 1-hour sessions. There was still only 6 of them. So we really did have to go back through the training interventions and think, what is the core message that we want to get out of these sessions? So there's some pros and cons to both of that. I think some of us occasionally felt that we were maybe having to rush through some of the content, but we know, and I'm sure you're all aware, after you've been on Zoom for an hour, you just get Zoom fatigue. It's not fair or appropriate to expect anybody to be on Zoom for more than an hour. So we thought, let's give it a try and see if we can get all of the necessary content that we want captured into 1-hour sessions. And we conducted the pilot with one home care agency based up here in Bradford, and it was myself and another researcher who conducted the training sessions. And what we were also asking the agency to do was to provide 2 clients who were living with dementia from their agencies, so that we could sort of try to link the training content to the real world. So to talk about real people who are currently maybe experiencing some of the challenges that we wanted to discuss. And then what we're in the process of doing now is some qualitative interviews with those participants who took part in the training, and we're going to support them during an implementation period. So we've done this in previous studies, but we will keep in touch with this agency for at least 3 months and have regular conversations with the staff who took part in the training, just really to see how it's going. Is it working? Has anything that we've taught them and that we've discussed as a group had an impact on practice, or is there anything that they're really struggling with? So we're in the process of starting that now. And maybe in 6 months' time we could give you an update about how that's been. But we've found in previous studies that that's been really valuable to ensure that it's not just a tick box training exercise, that it really is trying to influence practice. So that's what we're hoping to do there. So on the next slide, Debbie, I'll just give you some reflections really from the process. So I think we were all anxious because I personally have never delivered training via Zoom before. So we were worried about whether the group dynamics would work, whether people would just sit there on mute the whole time and have their cameras off and, you know, not talk to us, and it would just be me talking into the abyss for an hour for 6 weeks. But actually that didn't happen at all. The group were extremely interested in the topic, which you would probably expect because they agreed to participate. But actually they really all seemed to contribute, and Dan and I, who's my colleague who did this with me, we were reflecting the other day that actually the group, even on Zoom, still seemed to have that kind of dynamic conversation between each other, even though they're just small boxes on a screen. So that seemed to work really well. It wasn't kind of a static one person talking, me responding, another person talking. We did get that kind of dynamic group feel, which was lovely. Everybody was very respectful and friendly. And it felt that people really enjoyed reflecting on their own practice. A lot of the participants said to us, you know, we never get the time to stop and think about some of the brilliant things that we do, or for anybody to even praise them actually about how well they're doing, and the things that they, I think, take for granted that they do are actually fantastic examples of really person-centered dementia care. So I think they really enjoyed that element. And then from a kind of practical perspective, obviously it meant that nobody had to travel anywhere to go to the training. We didn't have to pay for rooms. We felt very guilty that we couldn't provide any refreshments to anybody, but we encouraged cups of teas and cake if people wanted it. But it does ultimately mean, if we're thinking about a rollout of such a training intervention, it could be a lot cheaper than if we were delivering face-to-face training. So that was one of the pluses. In terms of what didn't go so well, just on the next slide, Debbie. The issue that we were finding, and I don't think we'd really considered this fully, was that what was the best time to hold the training for everybody that wanted to participate. And we were in a slightly fortunate position with this agency because they have set rotas for their staff. So the shifts were from 7 o'clock in the morning till 2 o'clock in the afternoon, and then nobody worked from 2 till 4. And then the next shift was 4 p.m. till 10 p.m. So we always set the training sessions at 2:30 in the afternoon every week. So they'd had half an hour to either come off their shift, or they had half an hour before their shift started. But what we hadn't anticipated was that some people would work double shifts, and that's probably just our naivety. But we had some people who had started work at 7 o'clock in the morning, were working till 2 p.m. We were then asking them in their break to do an hour's training, and then at 4 p.m. they were going back on till 10 o'clock at night. So people still did attend, but you occasionally did feel, gosh, this is a lot to be asking people, and it's a lot for them to take in when it's really their only downtime that they have in the day. In terms of recruitment, we're slightly, I mean, it's the case in all research, but did we just, you know, recruit the very keen home care workers who provide brilliant dementia care anyway? So that's something we want to reflect on. And one of the parts of the sessions that we asked people to do, and we've done this in previous studies, but it really didn't seem to work particularly well, was to ask people to do what we don't really like to call it homework, to be quite honest, but it's really to go away and write down some reflections about what we had discussed. And we were finding that nobody was really doing that. They were spending the time thinking about it, and they came to the next group and did reflect, but they very rarely wrote anything down. So it'll be interesting to see when we do this in other agencies, if that was just an agency specific phenomena, or whether actually asking people to write things down is just not the best way for them to learn, really. So just to finish off, I'll just show you the next step. So you can go 2 forward, Debbie, if you like, back to the roadmap. So you can see the red car again, is that we've passed point 3 on the map. So we've done the pilot. So now what we're going to do is a randomized feasibility trial. So we want to do this in 3 different agencies across the country now, so not just Bradford. We're hoping probably one in London, one in the southwest, and another northern agency, with a greater number of home carers. So we only used 6 to 7 there, but we actually want a lot more home carers to take part. And we're going to ask them measures about whether they think it's improved their confidence, their skills in caring for people with dementia, and we'll ask their clients who are receiving care whether they think their care has improved, most importantly, as well. And then we will obviously do an analysis of, and an economic evaluation as well. But like we said, with Zoom, it will be a lot cheaper than originally intended. So that's the plan kind of going forward. Just to wrap up on the next slide, Debbie, is the information about NIDAS. If anybody does want to take part in the NIDAS family aspect that I mentioned earlier, we have Twitter, who doesn't, and this is our recruitment poster. So I'm happy to email this to people. And on the next slide are my contact details and the centre's information as well. So thank you ever so much for your time. And I'll hand back to Clarissa now.
Thank you very much, Catherine. It was really interesting. So we are going to have questions and answers at the end. So if people want to post some questions in the chat box throughout, that'd be great. We'll be picking them up afterwards. And now handing over to Dr. Sadia Paveen, colleague of Catherine's, and she'll be talking about improving the dementia care pathway for minority ethnic groups. Hi, Sadia.
Hi everyone, thank you Clarissa, and thanks Catherine, that was really interesting. So as Clarissa mentioned, I'm going to be talking about family carers as opposed to domiciliary carers. So this is the Caregiving Hope study, which I'm only going to present a small part of because it was quite a large study and it was funded by the Alzheimer's Society. So if we could have the next slide, please. I'm one of those people who cringes when Chris Whitty says that, and now I have to say that as well. So as I was putting together this slide, I was very aware of how out of date our current statistics are with regards to how many people are living with dementia in the UK and how many carers there are, but they're the best statistics I could find for now. So approximately there's about 670,000 relatives who provide care for a person with dementia at home, and they're thought to save the NHS and social services about £11 billion per year. The negative impact of caregiving has been really well documented in research. However, there are more and more carers who will be relied upon in the future, and we haven't really considered that. I've been talking to carer organisations this week which have kind of emphasize this as well, that with the current situation, more and more family members are less willing to have the person with dementia go into care homes, particularly what's happened with COVID and the first wave and how care homes really didn't do too well in the situation. So more and more people are going to be providing care at home. Could we have the next slide, please? One of the things that carers told me quite a lot before we started this study, that it's often assumed that family members are willing and prepared to provide care at home, and that's not always the case. So if you look at the lady who's wearing a hijab, she might feel culturally obligated to provide care, but does that mean she's willing? Because they're not necessarily the same thing. And the lady in the blue, she might feel willing to provide care, but is she actually prepared? Is she actually ready for what the care role involves? Next slide, please. And that's what the key concepts of the study were. So the three things that we were interested in was cultural obligation, and the academic term for cultural obligation is familism, and it's defined as a strong identification and loyalty amongst family members, and it's considered to be at the root of caregiving. And all cultures subscribe to this concept of familism, but some cultures subscribe more to it and others are more individualistic as opposed to being family oriented. The second concept we were interested in was willingness to care, and that's basically an individual's attitude towards providing support for a family member, whether that's a current need or a future need. And finally, preparedness is simply how ready someone feels to provide support to a relative. Could we have the next slide, please? So in this study, we wanted to find out how obligated, willing and prepared family members felt about providing dementia care, and whether the three concepts were linked together, and more importantly, whether they were related to carer outcomes. The outcomes we were interested in were a combination of positive and negative outcomes. So we were interested in what the carers gained from the role, but also how burdened they felt and how anxious or depressed they felt. And then we were also interested in whether there were any cultural differences between white British and British South Asian carers. Could we have the next slide, please? So what we did was we asked 186 South Asian carers and 518 white British carers to complete a questionnaire. The numbers might seem a bit random. That's because we were a rare study and we over-recruited. So our aim had been to actually recruit an overall figure of 340 carers to power the study, but we recruited way over 700 because people were so interested in taking part, which was absolutely fantastic. So we ended up with 186 South Asian carers and 518 white British carers who all completed a questionnaire measuring those key concepts and the carer outcomes, and they did the questionnaire 3 times over 12 months, so we could see changes over time. And then in addition, we interviewed 11 South Asian and 10 white British carers, again 3 times over 12 months, to see if there were any changes. With the interviews, we were particularly interested in what helped carers feel prepared for their role, and what were the coping strategies they used, and we gave them a disposable camera to capture those moments so that we could use them in interviews to discuss those concepts, because the concepts are quite abstract, whereas when they took photographs we could talk about more practical coping strategies that the carers were using. Could we have the next slide, please? So the results of the questionnaire study were, next slide please. So where there's a cross in the table, that means that there was a statistically significant difference. So not surprisingly, we found that South Asian carers felt more culturally obligated to provide care for family members than white British carers. But then things got interested when we came to measure willingness. So we measured 3 types of willingness. So whether someone was willing to provide emotional care, whether they were willing to provide instrumental care. So with instrumental care, things like whether you're willing to cook for the person, whether you're willing to clean, take them to the doctor's appointment. And with nursing, it was more around personal care. And what we found was that white British carers were more willing to provide emotional and nursing care compared to South Asian carers, but there was no statistical difference when it came to providing practical care. So both South Asian carers and white British carers were equally willing to provide that practical care that comes with living with someone at home with dementia. Not surprisingly, again, the white British carers felt more confident in their role. They also felt more prepared. However, South Asian carers were more likely to report gains from the roles or positive aspects that they'd noticed as a result of caregiving for that person, so such as learning new skills, gaining more independence for themselves. South Asian carers reported significantly higher levels of burden than white British carers, and also depression. When it came to anxiety, the South Asian carers did have higher levels of anxiety, but it didn't reach statistical significance. It's also worth saying that 2/3 of our entire carer sample reached clinical levels of anxiety and depression, and that's quite a significant finding and quite a scary finding as well. Could we go to the next slide, please? The next one, please. So this table looks quite messy, but basically, if the square is blank, that means there was no relationship between the 2 concepts. If there's a cross, it means there was a positive relationship and it was significant, and minus means there was a negative relationship. So as you can see, familism wasn't really linked to any outcomes for South Asian carers, but did have relationships with gains and burden with white British carers. The most interesting finding for me was that preparedness was linked to all outcomes for all carers. So the more prepared carers felt, the more gains they experienced, and the more prepared they were, the less burdened, anxious and depressed they felt. So after the three concepts we were interested in, carer preparedness seems to be the one that we would need to tackle in the future to improve outcomes for carers. Could we have the next slide, please? Because we did the study over 12 months, we were able to see if there were any significant changes over time. And the surprising finding was that we thought that cultural obligation, familism, would be ingrained in a person and wouldn't necessarily change. But even within 12 months, we noticed a significant change. So after 12 months, carers felt less culturally obligated to provide care, which is interesting. We're not quite sure. The interviews revealed that it wasn't so much that they felt less culturally obligated, but they cared less about what people said about them for not fulfilling their duties. So they were still aware of the cultural obligation, but they cared less about fulfilling that obligation 12 months later as they realised how difficult the role was. Confidence in caregiving improved over time for all caregivers, as did preparedness, but unfortunately caregiver burden also increased over time. There wasn't any significant change with regards to anxiety and depression. Some slight increases, but not enough to meet statistical significance. Could we have the next slide, please? So as I mentioned, we interviewed, it's okay, we could go to the next slide. So as I mentioned, we interviewed 21 carers over 3 time points. Back in 2013, or it might have been 2012 even, Carers Trust released a report where they outlined 10 transition points for carers that were considered stress trigger points and where carers needed the most support. So they ranged from the person actually receiving a diagnosis, as a carer taking on an active role, right towards the end when the person had to be moved into residential care and when carers had to make end-of-life decisions. So we used this report to purposely recruit people who were going through these particular transition points. So we had a few carers that were at certain transition points, and then over the 12 months they either remained kind of in the same situation or they kind of progressed through more transition points, and those were captured in the interviews. Because I only have 20 minutes to present, I can't really discuss with you all 10 transition points and the cultural differences between the South Asian and white British carers, but I will quickly talk you through one of the themes. Could we have the next slide, please? So one of the transition points that's labelled in that report is preparedness for behavioural problems. Now, we wouldn't necessarily use the term behavioural problems, it's not very person-centred, but the carers themselves refer to it as behavioural problems, and in this study I wanted the carers to have the active voice rather than us having the academic active voice. So I have kept that term behavioural problems. I picked this theme to talk about because the contrast between the white British and the South Asian carers was really, really interesting. There's a lot of literature around awareness of dementia in South Asian communities, and that literature has mainly focused on the general public or occasionally carers. There's very little on what people living with dementia and the active family members think themselves about dementia. And what this project revealed was the effect of the really active dementia awareness, dementia friends work that's been done, and some of the side effects, the negative side effects of that work, which were interesting and maybe unexpected. So there's no word for dementia in South Asian communities. So the way the dementia awareness work has been delivered is that dementia has been translated to mean memory problems. Now that seems like an easy way to get around it, and it makes sense. Most people with dementia have memory problems. However, in the South Asian community, most people have vascular dementia, which isn't always related to memory problems. So that's caused a lot of confusion among the South Asian carers. They all now have the key messages sort of ingrained in them. They do realise that dementia is not the same as aging. They realise that dementia is a disease of the brain, but they also think that dementia is just memory problems, because that's what we have told them in our dementia awareness work. So when it comes to the person having more complex needs and maybe having unmet needs, which lead to what carers refer to as behavioural problems, the South Asian carers really struggled with this transition. So they felt they already knew about dementia because they'd gone to the dementia friend sessions and they knew dementia was memory problems, but the person wasn't dealing with memory problems. They were dealing with a person leaving the home in the middle of the night and getting lost, or the person having personal care problems, or the person being aggressive. These were things that they did not associate with dementia, and they didn't understand why the person might be behaving like that, and they often blamed the person for those problems. So that person was doing things on purpose. They were leaving the house at midnight and getting lost on purpose to cause problems for the family. And the way they dealt with this was a reliance on the GP and antipsychotic medication. Every single South Asian person that was involved in the interviews, the person living with dementia was on either taking sedatives or antipsychotics. And they all went to the GP and they felt the GP was a person to solve these problems, because it had nothing to do with dementia. There was something else wrong with that person. And it was verging on very non-person centered, and you could even maybe refer to at times abusive care, because the carers had no understanding. They didn't want to be abusive, but sometimes they would have to restrain that person because they just didn't understand what was going on. When we looked at the white British carers, it couldn't be more different. So the white British carers expected the person to advance from memory problems to having other problems. They were already expecting that and therefore felt more prepared for it. They also interestingly understood that these behavioural problems were unmet needs. They used that term unmet needs, which I found really interesting. And they actually didn't blame the person, they blamed the environment for triggering that person. And they went to great efforts to maintain a trigger-free environment. Those were the exact terms that they used. And they had great interest in involving the person in lots of social activities to reduce these behavioural problems. So they often took people out to wellbeing cafes, to different activities, and they felt that these activities helped the person maintain their personhood and to live better with dementia. And they were very against using medication, which was complete contrast to the South Asian carers. Could we have the next slide, please? So we'd asked carers to take pictures of things that help them feel prepared and things that help them cope. And I just wanted to share some examples with you. So we've got an example here of people cooking. And in one of the families, there was a male carer whose mum had early onset Alzheimer's disease. I think she was in her early 50s. And the family had decided that she was no longer allowed to cook, even though she had cooked for the family all her life. But they just decided after the diagnosis she couldn't cook because people with dementia weren't capable of that. But he had attended the Alzheimer's Society's carers course for dementia, how to cope with dementia and how carers could look after themselves. And because of that course, he'd gained an understanding of how psychosocial activities such as cooking might actually be helpful for the person living with dementia. So he'd started cooking with his mum so that she could carry on doing the activity that she loved, and they shared that picture with me. The middle one, the doggy, the really cute dog, that was taken by a white British carer who was looking after her mum in her 80s, who was also living with Alzheimer's disease. This carer was very unwilling to support her mum in the sense that she wanted to maintain her own independent life and not be too involved with her mum's life. They'd previously had a bad relationship, which had resulted in this situation. But the way she got around her guilt of not supporting her mum was to buy her mum 2 puppies. So she bought her mum 2 puppies, and she was convinced that the dogs would provide the support that her mum needed, and therefore she was exempt, and it removed responsibility from her. And that was her strategy with managing the caregiving situation and the lack of willingness to care. It almost felt like she kind of bought the dogs to do the caregiving role for her. But apparently the mum it did help the mum, and the mum absolutely loved playing with the dogs and taking them out. The third picture was an interesting one. So this was a white British husband providing support for his wife, who loved going out for walks, but as her dementia progressed, she couldn't identify her house any longer, and she kept getting lost. They lived in a neighbourhood where all the houses looked the same, and they all had the same doors and very similar well-kept gardens, and she kept getting lost. So he actually put in this quite outrageous door so that she could spot it from far away and be able to come back home. And what was really interesting about this carer was that he was very practical oriented. So every strategy he came up with was very practical, but he talked about how much he struggled with the emotional care, because that's something his wife had done previously. He, as a man, just knew how to fix problems. And I think that picture kind of really reflects that nicely. So I wanted to share that with you. Could we have the next slide, please? So one of the main outcomes of this project has been that we've had a really active PPI panel. So we've had carers, members of the public and carer support workers who came together, and they took the extracts from the interviews and the pictures, and they've produced Tips for Carers booklet, which I've tried to hold up here, Blue Peter style. And this book is split into the different transition points, and it provides tips to other carers on how to cope with the caregiving role and what's worked for other carers and what might work for them. It's interesting because we won a dissemination grant, and we printed, I think, 1,000 copies of this book, and we managed to get out about 200 copies, and then lockdown happened, and the book now lives at the University of Bradford, and I'm at home, and I haven't been able to disseminate it. So what we've done is we've created an ebook which you can now download directly from our website, along with the results summary, which also we had like a booklet that we were sending out to everyone, but you can now download both directly from our university website. The next stage for us is to start developing and co-designing interventions that support carers to feel more prepared for their role. We've disseminated the findings to lots of different care organisations, and they've taken the findings to make little changes to their services to help them be more culturally sensitive. Next slide, please. So this is the PPI group I mentioned. These are the people who have been working with carers and members of the public and carer support group, people who have helped with the study all along, and just wanted to thank them. And we've got academics from University of Bradford, Professor Jan Oyabody, Bangor University, Professor Will Morrison, and Professor Rick Fatinsky from University of Connecticut, who have also been involved, so thank you. Final slide is just my contact details if anyone is interested, and that's the website address where you can download the results booklet and the Tips for Carers booklet as well. So thank you.
That was great. Thank you so much, Sadia. Really, really interesting. Well, thank you both, Catherine and Sadia. I've even written down a few questions, but I think we'll check first what the audience has put down as questions. And as I mentioned, please feel free to just pop down any questions in the chat box now. We'll go through them now. So maybe there were a few questions first for you, Catherine, if that's okay. So particularly quite a bit of interest for your NIDA study. I think you may have a few potential recruits here even soon.
I'm pleased about that. That's good.
So just trying to scroll up. Just hang on with me. There we go. So, well, first of all, is NIDAS a national study, and can families join the NIDAS pilot from anywhere in the country?
Yeah, so it's a really good question. So originally, obviously pre-COVID, it wasn't a national study. So it's predominantly was being recruited. Our patch up here in Bradford, we'd sort of cast the net as West Yorkshire. So about an hour from Bradford is sort of the reasonable travel. And similarly in London, we were just saying about an hour's journey for the research assistants from London. Now, because the intervention has moved to Zoom, actually what we have done is just open it up to anybody in England, specifically just England, not Scotland, Wales or Northern Ireland, but anybody in England who wants to take part. If they're happy to do it either on Zoom or via the telephone, about 15% of the people that have taken part so far have not felt comfortable using Zoom and have preferred to have just a telephone conversations with the researchers, which is absolutely fine. So yes, it is. We had a meeting with the Alzheimer's Society actually just before Christmas, because they wanted to discuss whether we would ever go back to offering face-to-face. Now, the ultimate goal would be yes, to go back to face-to-face, because we do know that people generally prefer that, but we would like to, for the rest of the study, offer online for people who do live in, say, more remote areas or are not based near the researchers. So yes, it is now national, but if all the restrictions got lifted tomorrow, we wouldn't be able to visit people that didn't live within an hour of, say, West Yorkshire or London. Does that make sense?
Yeah, I suppose in a way, as negative as COVID is and has been, maybe that's also been an opportunity to kind of branch it out for anyone to access it.
Yeah, I mean, it's there's two sides to the coin, isn't there? It's exactly that. It's that we've potentially been able to recruit more people from areas that we wouldn't have been able to. But equally, we've been slightly concerned that have we maybe excluded people who are not comfortable with the technology aspect of it. And, you know, we've tried really hard to support people to feel comfortable using Zoom, for instance. And the feedback that we've been getting has been really positive, and that actually people like that they don't have to schlep to the university to be seen or have a stranger actually in their house. You know, it is there are benefits to it for sure, but I do think I think if we could have the perfect scenario, we would be able to offer either face-to-face or on Zoom for people, but who knows, hopefully by the end of the year that will be the case.
Yeah, just one question on that, because you're talking you can access more people. Do you think there's a limitation in terms, or maybe a potential inequality in terms of some people might not have that access to digital technology?
Yeah, I mean, definitely. I think COVID's highlighted that. I mean, they've said COVID's the disease of inequality, isn't it? Really, I think it's highlighted that digital divide, not just for older people. I think for everybody, really. If you look at people trying to homeschool at the moment, it's a similar situation. So we have been very aware of that, and actually, I mean, I didn't talk about it too much, but we had to stop. We actually had to pause recruitment through the NHS, obviously, because they are pulled into COVID related matters at the moment. Some of them have started recruiting back up for us, but actually our recruitment to begin with was predominantly through social media and through emailing in our networks. So already we were targeting people who had that digital kind of arm, you know, string to their bow. So we definitely do think about that, and we've said to some of the sites, actually, if you can identify people that for whatever reason maybe don't have access to a laptop, or it's slightly harder with internet and providing data, but we have the resources within the project to loan computers to people so that they would still be able to participate. We really don't want it to be a barrier, but it's, like I say, I don't think it's just a NIDAS phenomenon, unfortunately.
No, yeah. Care homes as well, as we've starting to
Totally,
realise.
Yeah.
So Peter was asking, will participants in the training module get a certificate for having taken the course?
Yeah, they do. They get a very well designed certificate by one of our research assistants. But we've been thinking about this more and more, because for anybody that's familiar with the home care sector, actually the sector is trying to professionalize themselves more and more. So there's actually very little training requirements at the moment for paid staff going into people's homes. So they're trying to think about what would be the equivalent that nurses have to go through for training, obviously not getting them to do a degree, but what are some of the kind of rigorous training that they would have to go through. And I think ultimately we would like NIDAS to be a part of that kind of professional package, because obviously dementia care is only one aspect of the care that they will be providing. But yes, at the moment it's just a very kind of basic UCL Bradford certificate, but we would hope that it could become part of a more rigorous package of training that people access.
Yeah, definitely. So there's more to come, I'm sure. Thank you. I mean, we'll get back, but I just noticed quite a lot of comments as well on your talk, Sadia, and on your research here. So lots of positive comments from people. So Rebecca was saying really lovely work. The point about carers having low understanding of non-memory cognitive impairments and behavioral problems is really important. Ben was saying study is important, thanks for the work, and will this work be published in a report soon? I suppose, is that linked to the PPI report you were referring to as well? Is that some of the findings?
Yeah, so we've written quite a few reports already, so the reports are out there and all the results are in this, which I'm going to post a link to for everyone in a minute once I figure out how to. So the reports are all out there and you can download the summary of the results, and we're currently publishing some of the papers as well.
That's great. Yeah, I've seen you posted the link to some people already. So David was asking, I'm not sure whether any of you is aware of it, so he would be interested in joining the research programme. Is there something similar available in Wales?
Is that for NIDAS?
I am not sure.
Yeah. If it's been, I can answer for NIDAS.
Yes, go ahead.
That currently, no, we're not recruiting in Wales. Purely, it's an ethics kind of. We were recruiting through the NHS, so we had to save the site. So we just decided with England, because actually, what we were finding in the other nations was that the structure and the commissioning of home care varies quite significantly across the different countries that make up the UK. So we decided actually just for, to be quite frank, ease, we would stick with England and start there. But I do know that colleagues at Bangor, which I know Sadia works closely with colleagues there, and at Cardiff University do a lot of work trying to support family carers. So if you are based in Wales, it may be worth having a look kind of more locally to see what's going on. But definitely, as the project progresses, we would hope that this would be taken up across all 4 nations of the UK and beyond. So we'd be very keen to work with people in the future who are in the different nations for sure.
Yeah, and one question from Anonymous as well, Catherine, has the training that you're doing, the NIDAS training, so far been cross-referenced with the Skills for Care, Dementia Core, Skills Education and Training Framework?
It has, yeah, which is a very informed question from whoever wrote that. So actually at the University of Bradford as well, the team, and Sadia is actually leading the next piece of work on this, is the core training that Health Education England roll out for all of their NHS staff as well. So we really didn't want to reinvent the wheel with what we were doing, but we really felt that there was quite a specific gap for this profession about the type of care that they were providing. Quite often, a lot of the people that they work with don't have a diagnosis of dementia actually, but have dementia. It's just that they haven't had the diagnosis. So it may not be as sort of glaringly obvious that those individuals need dementia care and support. So we were really trying to pick up on those clients as well. But yes, we've really tried to ensure that it links to all of the kind of mandatory training that's being rolled out. Great.
Sadia, I've noted down a few questions about your work as well, which was really interesting. I've got a little bit of background of this myself, but I wasn't aware, like with the medication in particular, I picked up that people from South Asian backgrounds are more likely to just want to go for medication to treat whatever symptoms someone with dementia or memory problems has. I thought that was really interesting and almost a bit shocking, I suppose, as well.
Yeah, I think I was quite shocked as well, because I hadn't expected that. I think there might be, well, we can't, because it was an interview based study, that aspect, we can't come up with any causes for that, but we have to understand that there might be two potential links. So I think the South Asian culture does buy more into a biomedical perspective of illness compared to like a psychosocial. Every illness has a tablet. There's lots of comedy around it in the South Asian culture about you can just get a tablet for any illness, no matter what. And then the other thing is that I'm not criticizing the dementia awareness work. I think it's been absolutely brilliant, but I think the translation has been tricky, and people have tried to really kind of hammer down the key messages, and telling people that it's a disease of the brain kind of translates to therefore it can be treated by a tablet.
Yeah.
And people have not really understood the psychological and the cognitive aspects of living with dementia.
Yeah, and I think that was linked in. It kind of seemed that there's still quite a big need to raise awareness and education within that minority group.
Definitely, I think there does need to be more in-depth work that needs to be done, and I think someone in the comments mentioned whether Dementia Friends is the same for all communities. So my understanding is that there is, they have a culturally specific one, but it's just basically translated into the language of whoever you're delivering it to, and it all comes down to how well that translator's been trained and what understand. So a translator needs to be trained in dementia care as well as person-centered care, as well as being able to translate, and that's not always happened. So I've been in Dementia Friends sessions where the translator, because I can understand the English and the Punjabi, they've used really derogatory terms, and me being me, I've had to step up and say, actually, that's not what dementia is. They're not. So they use the word pagal, which means mental or crazy, and I've had to say, no, dementia is not craziness. But it's not the translator's fault. I don't want to blame anyone, because they've just not had any training themselves. So they're trying to translate into words that they know. So I think that's caused problems as well. So I think, whereas it's been fantastic that we've tried to emulate Dementia Friends, maybe we need to have a deeper think about how we translate that information across different communities.
Definitely, that's really interesting, and I think there's lots of other minority ethnic communities where still so much more work needs to go on and actually be implemented in practice. So
can I just add to that as well? And it's a really interesting point from a professional's perspective as well. So a lot of the home care providers, that the home care staff particularly, you know, they're not, maybe not, English isn't their first language, they're not from an English background, or culturally they're not from a white English background. So also we're seeing those differences there about their understandings of how you best care for people, and some of those assumptions there. So yeah, I also think it's not just for family carers that we need to be doing that work, it's also for professionals who might be similar to the work Sadia is doing, for sure.
And in a way, it might be more important to train up the professionals to be able to spread that information.
Yeah, definitely.
No, really, really important. And I suppose not just home care workers, but also generally health and social care professionals that do work with people living with dementia and cognitive impairments.
Definitely.
Okay. I'm mindful of time, and that's been really, really interesting. Thank you so much, Catherine and Sadia. So we've had some really interesting questions as well and comments. Thank you so much. Debbie, would you mind for the next slide? So just to kind of make everyone aware, our next webinar in March, we'll see another University of Bradford dementia researcher.
We're taking over.
Newly appointed Professor Siobhan Riley, who's previously been at Lancaster University, and Dr. Andrew Harding, and they will both be sharing their work into what really matters to people living with dementia. So I've also posted the link to the Eventbrite in the question box. But yeah, so hopefully we'll see you then again. And again, thank you so much, Catherine and Sadia.
Thanks, Clarissa.
Bye, everyone.
Thank you, everybody.
Bye.